Okay. So, good evening, everyone, and welcome to yet another session of Brain on Wednesdays. And I am taking Dr. Rajkumar's place today because at Baroda there is heavy rains and a problem with continuous electricity supply. So, sir is in and out, and he has requested me to take over today's session. We have a very interesting session today, and the speaker is Dr. Nachiketa Desai. Chairing the session is Dr. Hinal Shah. She is a professor and head department of psychiatry at Nayar Hospital and a very good friend of mine. Apart from being an excellent clinician, her specialty being child and adolescent psychiatry, she is also an excellent teacher and holds a master's in medical education. We welcome you, Dr. Hinal Shah, uh, and I am handing over the mic to you. You may introduce the speaker and the topic, and then we can take on from
Thank
there.
you, Malai. It's always good to be with friends. So thanks to you and Rukshada and Rajendra for inviting me here today. So, you know, obviously we all meet on live CME, and every time I read some of those posts, I wonder what they're talking about. So many changing concepts. And I think when we thought of COVID and they started talking about using antidepressants to increase immunity, or when we started talking about using antidepressants, as we call it, for schizophrenia because it's also anti-inflammatory. So many new things are happening in terms of our understanding of neurobiology, in our understanding of how we view what causes drug, and eventually with the hope of precision medicine. And when all these discussion goes around, one of the bright young stars, besides, of course, the galaxy of Bhaskar, Malais, and the likes, is also Nachiket Desai, who always quips in with something interesting to say and a whole load of articles which he tells us to read, which is unfortunately very difficult, but he makes it simpler by giving a précis. So we have with us Nachiket Desai, who is a psychiatrist trained in Gujarat, working in Navsari, very much interest, has his private practice, but very academically inclined, and has a great interest in neurobiology, and most importantly, seeing to it that it goes from the bench to the bedside, not only for him, but for all of us. So therefore, today he's here to discuss this topic of what are the basics in repurposing and repositioning medications or drugs in psychiatry. So over to you. You have the next 40 minutes to um, tell us more about of this. You may call it basics, but I'm sure it'll be quite new and interesting for the most of the people here. And may I request them to put their questions on the chat, and we'll take them all up in the end. All yours.
Thank you, ma'am. Hello, everyone. Hope I am audible. Hello.
Yeah,
You're audible. And before you begin, I would request everyone to put themselves on mute. It creates some disturbance to the speaker. And as ma'am said, please put your questions with your name in the chat box, so it becomes easy for us to identify whom we are addressing and talking to. And with that, over to you, Nachiketa.
Thank you, sir. So today I am more of a discussant rather than a speaker. I would be learning along with all of you, because even though the topic may be there, each revision or each replay of thought process teaches us something new. To save bandwidth and prevent any interruptions, I would turn off my video and start screen share. Today's topic is drug repositioning and repurposing. Now the thing is, there are overlapping terms and sometimes they are confusing, but we are trying to cover it all under one umbrella, and that is our today's topic. Why do we want to discuss about this topic? Because as ma'am has said, there are multiple uses of one medicine, and sometimes those uses are either serendipitous or not something we thought about before. So just to give an idea, I'll start with the basic definitions. These are the various terms. There are other terms also, but these are the common ones. Drug repositioning, that is finding new uses outside the scope of original indication. Drug repurposing is primarily identifying, developing, and commercializing new uses for existing or abandoned drug where patent has expired or for other reasons. Drug reprofiling is for the studying the drug in new light. One drug which has already undergone preclinical and clinical testing, so that part is already covered, safety aspect is covered, and now we are looking at it in new light. Drug rediscovery, old drug re-emerging, drug reformulation. Sometimes a change in formulation can help with certain things, as we'll see in terms of propranolol later on. So overlapping terms, and most of the times they are used interchangeably. Not that big of a difference, but semantics are there. Why do we need to repurpose? This diagram is for traditional drug discovery and development. It starts with pen, paper, book, research. There are thousands of compounds in consideration. Then there are some studies and certain modeling. At preclinical level, that number that was in 10,000 or more boils down to 250. Of them, hardly 5 go to trial. Of them, hardly 1 or 2 get FDA approval. And whole process takes about 14 to 15 years, if you see at the bottom line. Now, as we discussed in previous slide, once drug safety and certain profile is established in preclinical trials, we have that part covered. So a reposition drug would directly enter into maybe some animal studies if needed, but most of the times clinical trials. That reduces the time and resources involved. This is one another important area. There are rare diseases which very low prevalence, so low that R&D is not affordable for majority of companies. So hardly 5% of pharmaceutical industries take interest in developing new drugs for these diseases. Drug repurposing saves those resources and thereby allow exploring treatment options for rare diseases also. Other than that, obvious advantages are cost effectiveness. It saves time, especially like COVID pandemic, where time is of the importance. It also reduces animal testing, which has ethical and other aspects involved. The potential for reuse of failed drug molecules. Let's say a molecule was being developed for an indication, but it can happen that it did not show adequate effect and it did not survive the market. However, later on it gets rediscovered as a molecule with different indication. The goal is to quickly identify compounds which have established safety profile and therapeutic advantages that can help in other indications. This is a way to demonstrate and the number of resources saved. All in all, there are different numbers, but we can say that with repurposing, the timeline cuts short to half, expenses can cut short to almost 1/10, and still there is higher success rate than starting from scratch. So how is it done? There are different approaches. Main three approaches are either it is a drug-centric approach where we are studying a drug, its profile, and thinking about what other indication it may have. Or it can be target-centric. Let's say a receptor, maybe dopamine or something. And then we are thinking about that receptor, what other meds can bind to that receptor and show the desired response. Or it can be disease-centric. Now this one is important because we would have to have a disease model, and there would be different steps where different medicines can enter, and based on that model we try to work on what suitable molecules are available in market. For disease centric approach, we need to have a neurobiological context. For our specialty, that is psychiatry, we can think of it this way: psychiatric disorders are manifestation of CNS dysfunction, and whatever is affecting CNS is also likely to affect peripheral nervous system. For example, in irritable bowel syndrome, there is hyperexcitability of GI and neural networks. which is sharing pathophysiology with central dysfunctions also. And to go even more broad, psychiatric disorders or rather psychiatric symptoms are CNS manifestations of multisystemic illnesses. And that's why a similar pathophysiology or a dysfunction can present in different organ systems differently. And that is why our patients are already more prone to other non-communicable diseases. So something that can correct one particular type of dysfunction can actually help us treat more than one thing rather than just psychiatric disorders. So coming to target-centric approach, by and large, we keep hearing this term in repurposing and otherwise about on-target and off-target effects rather than effect and side effect. So whatever effect was intended to be exerted on a target or receptor is called on-target effect. Now, someday, if we get another indication based on the same target, then we can say that drug is repurposed for new indication, but it is on target. Whereas, let's say a drug is found to have a separate target or mechanism, and subsequent to that, we have a new indication, then it is off target repurposing. Other than that, when we talk of drug and its repurposing, we can look at drug profile, off-label uses already in clinical practice. We can look at phenotypic screening, or we can go computationally in 3D structure of drug, protein folding, what other drugs can be available. Drug designing mostly and designer drugs work in this area. Or we can again look at omics data, genetics, protein interaction networks, if we want to look at disease pathway and related repurposing. Or we can even look at clinical data, what were the disorders, what was the response, when was the response, what was the genetics and genomics of that response, and depending on that, we can again repurpose. So another way to classify this repurposing approaches is one, clinical based repurposing. We gave something for an indication, but additionally we saw something else happen, which becomes new indication. Or it can be experimental, where we do preclinical studies and other experiments. Or nowadays, by and large, it is in silico or computational based repurposing, which has multiple different approaches, ranging from molecular docking, knowledge-based graphs, pathway mapping. Machine learning is also gets involved to assess the patterns. There can be genetic association studies, GWAS. This is one example of how different approaches are divided. Some target-based approaches where we are looking at receptor and other targets of drug action, or it can be disease-related focus where we are assessing patterns, network analysis, we are classifying, and based on that, we are focusing on new candidates for repurposing. Or it can be this computational part, text mining, comparisons, shape that we were talking about, protein folding and such. And for those purposes, various databases are used. Different types of databases for protein structure, chemical structure, sequencing, pathways, protein-protein interactions. Of them, this one, CAC pathway is one of the famous ones, which indicates what intracellular pathway dysfunction is happening and how it can present as different disorders in different systems. This is just an example of that CAC pathway. Obviously, it is too detailed and complex, so whole could not be fit in this slide. But we can look at mTOR is here, P53 tumor related is here. There are other pathways, PI3K pathway, and how they lead to different disorders. And then what agents can target what part of this pathway intracellularly. Another example is Elsevier's immunology. It shows this graph kind of thing. This is in a way knowledge graph, where centrally there is CDK4, its upstream relations and its downstream relations in terms of cell processes, diseases, organ where it is more present, less present, how medicines affect them, how viruses and other pathogens affect them. Depending on those correlations, we can get a succinct view of relation of different seemingly unrelated entities. For example, here is IL-4 receptor related knowledge graph, just for an example. And based on that, we can devise newer targets and newer candidates for repurposing. However, all this is more on pharma side. What we as a clinician need to know about this, why drug repurposing is important for us. Number one, clinical utility. Awareness about molecule doing more than one thing. For example, if we recall, chlorpromazine was originally invented as antiemetic. Now it is used as antipsychotic, maybe in low doses, anti-anxiety also. And being aware about these different indications may help us select a molecule better. Another example, SSRIs are known to be good antivirals. They reduce infections not only by reducing stress and boosting immunity and all those things, but they directly have antiviral effects. This leads to better, more rational polypharmacy, which leads to cost effectiveness for patient. Now, the question is whether we are using a molecule for an indication that is not FDA approved. So the FDA approved indication is on label use, where the indication may be mentioned on the box or label. Anything else is in a sense off-label use. But off-label use is not same as experimental use. Primary difference being that experimental use is mostly in research setting. A drug or a molecule is under investigation. We are still profiling. We are looking at safety data, whether it is feasible for humans or not, this, that. Whereas most of the times, off-label medicine already has one or two FDA-approved indication, and it is already in market. After that, we are using it for different indications based on our either clinical experience or some sound medical logic. So common scenario where off-label uses are, number one, let's say two molecules, same mechanism we can use, or two therapeutic conditions possessing same pathophysiology we may be able to use. We may treat life-threatening conditions where no other treatment is available, but off-label use may have safe and effective treatment option. Or same drug, FDA approved for certain indication, but not approved for other population. There has been some cases about melatonin being approved for children, but not adults. So in that case, a melatonin used in adults would be off-label use. Then the question is why this particular molecule, why not the other molecule for same class? So the first point is, number one, if a molecule is generic, patent has expired, and now is freely available in market, it is beneficial from cost point of view for R&D and repurposing, whereas a molecule with ongoing patent will bear extra charges. Another point to consider, especially in case of psychotropics, is that even though we classify molecules in one category, they are not same. SSRI as a group is not same as, let's say, angiotensin receptor blockers. All molecules in SSRIs have different profiles. So that heterogeneity would mean that we cannot directly use one SSRI for another SSRI, although each has their own uses. Then the question of bioavailability. For example, among the tetracyclines, minocycline has higher blood-brain barrier penetration, so it is more suitable for CNS-related repurposing. And in some cases, similar molecules can actually be used. For example, we use sildenafil versus tadalafil. Same can be used for its original indication, that was hypertension or primary pulmonary hypertension and related things. So it's not always that we cannot extrapolate, but we have to consider whether the molecules we are considering are same or not. Now coming to some successful example, and then I'll talk a bit about the challenges. One, as we talked about chlorpromazine, it started as antiemetic, and it was noted that before surgery, when chlorpromazine was given, it used to help patients behaviorally also, keeping them calmer and things like that. Then over the period of time, its use as antipsychotic evolved, and then other indications slowly. But nowadays we are focusing more on second and third generation antipsychotics. This one article has beautiful list of 120 plus molecules alphabetically. What was the original discovery for and what is the repurposed use for that? It's worth going. I'll pause that this screen for a few minutes so that if someone wants, they can take a screenshot. Okay, so moving on. Ketamine. Nowadays, we are talking about ketamine and its role, its anti-suicidal property, euphoria property, or antidepressant property, but I tend to view it as rapid, short-lasting relief in depression. The dose used for this indication is less than the dose used for anesthesia. So it's a different dose for different indication, but yes, it is a repurposed molecule. Similarly, propranolol. This is the one where I was mentioning in context of different formulation, or we can call it reformulation. It is traditionally used for management of cardiovascular condition, tachycardia, and anxiety symptoms also. However, primarily it was started for cardiovascular reasons. Then it was found to be useful in hemangiomas. That babies with infantile hemangioma started responding to this. Because of that, a separate formulation was devised named hemangiol, which is a different dose than usual cardiovascular or anxiety-related doses. And then it was released under this particular license, pediatric use marketing authorization, and that primarily covers childhood related. So I would say that this is a reformulation type of drug repurposing for a new indication. Endoxifen, another star molecule since about 2016-17. It started with the focus on protein kinase C, which we can call disease model centric approach. And then it was found that original use as selective estrogen receptor modulator in cancer. It also had this intracellular pathway effect and other things which are actually more relevant for mania. And so now it is found to have almost equivalent effect to valproate in short period, some 8 to 12 weeks. But in future, if we focus on this protein kinase C dysfunction, we might be able to extrapolate that it is helpful in other areas with overactive PKC like impulsivity and aggression. Sildenafil, another famous example, started as treatment for hypertension, then shifted to pulmonary uses where it is still being used. And now it is being used as treatment for erectile dysfunction. But even today, sildenafil and tadalafil are used in prescription of pulmonologists for primary pulmonary hypertension. And dosage is, yes, again, there is slight difference. Prazosin and clonidine originally started as antihypertensives, primarily central antihypertensives, but they found to be useful in reducing central sympathetic overactivity, which helps in nightmares and even aggression. Clonidine we can use in even neurodevelopmental disorder related aggression and other conditions also. Now, unless and until these uses are approved by FDA, they are off-label uses. But one area which also affects this is whether a company is applying for approval or not. So off-label doesn't always mean that just we are using it without any evidence base. Minocycline, it was considered as for the treatment of psychiatric and neurological conditions. There are uses in schizophrenia, some use in depression also, but so far negative symptoms of schizophrenia and related things, they have shown some effect. It is most probably due to anti-inflammatory action because there was correlation with reduction in inflammatory biomarkers. There are different combinations available, which are also a type of repurposing where a different dose is used. One example is recently launched bupropion plus dextromethorphan. As such, it would lead us to think that primarily it is the bupropion that is working as antidepressant and dextromethorphan is there to just push it. However, what company or literature is saying is that dextromethorphan is primary agent for rapid response, somewhat like ketamine through mTOR signaling, and bupropion is there to elevate its levels. Similarly, quinidine plus dextromethorphan used for pseudobulbar palsy. Low dose naltrexone, again possibly a different dose for a different indication rather than actual differential effect. Hemangiol, as we talked about, propranolol oral liquid. And then there is a opposite direction of repurposing also, psychotropics used in other disorders. For example, this narrative review at psychiatrist.com from Journal of Clinical Psychiatry is a good starting point to read about these aspects, how psychotropics are being used for COVID-19, degenerative conditions, various cancers, even dermatological and other things that as we'll see. In oncology, list was too long to be included here, but there are articles on use of antipsychotics for repurposing as anti-cancer agents. There is literature available for SSRIs, fluoxetine and related agents as chemosensitizing and radiosensitizing agent. Let's say somebody is having renal cell carcinoma, which is not adequately responding to radio and chemotherapy. After introduction of fluoxetine, it starts responding, something like that. Then there is another big area in terms of oncology, that is chemotherapy-induced nausea, vomiting. There is good enough literature for role of olanzapine, amisulpiride maybe, and some other antipsychotics as antiemetics in those conditions. And sometimes they are responding slightly better to these so-called antipsychotics than even ondansetron and other agents. In terms of pain and chronic inflammatory condition, this area we are by and large most familiar with. We frequently see prescription of duloxetine or levomilnacipran or other SNRI or even tricyclics for that matter in chronic pain conditions, neuropathies. We also see prescriptions of anti-epileptics in similar indication. Extending to that into dermatological area, almost same mechanism. Chronic inflammatory conditions, psychiatric medicines are useful. For example, this article talks about fluoxetine, citalopram, desipramine, even topiramate, naltrexone, cannabidiol. All in all, they tend to help in recovery, especially in rheumatological and in a sense hyper-inflammatory condition. They have flare up when patient is under stress also, which we usually consider in terms of psychological stress, but technically physiological stress of any type. Gastroenterology, there is off the record dictum that half of the gastro practice is related to anxiety and psychiatric symptoms. Of them, IBS is one of the commonest example. Mirtazapine and tricyclics have role in main guidelines and main treatment algorithms along with stress management. And there are obviously we will have to look at the individual symptoms. If some person is having constipation dominant symptoms, then we'll give molecule accordingly. If somebody has, let's say, diarrhea prone symptoms, we might use tricyclics. This is where knowing about different indications and different effects of a molecule can help us select a suitable molecule in such a way that less number of medicines can cover more symptoms. So these were some examples, but there are challenges also. Not all repurposing are successful, and then somebody may not even take up R&D. From pharma company point of view, intellectual property protection is relatively weaker. Medicine is already researched by and invented by, or rather discovered by some company. That company holds right. The company doing repurposing related R&D will get primarily the rights related to that particular indication and dosage form. There is some lack of clarity in regulatory pathways, some lack of financial incentives, and the other challenge is to convince clinicians that already existing drug can be used for a completely new indication. For example, I have experienced this when I wanted to use clonidine for certain indications, and I had to collaborate with physician, and he was of the opinion that why are you using clonidine if patient does not have hypertension? Although after detailed discussion, physician did agree for that and patient actually responded. Technical challenges are also there in terms of how to maintain the data, whether it's data hygiene is maintained or not, because if you are pulling data from available articles and literature based like the MBase thing, then it has a potential to dilute things because different molecules, different same molecule for different indication, different population, that heterogeneity affects. Then there are tooling and platform barriers. We discussed about those databases. It may not be accessible for everybody, and not everyone would have enough technical expertise to actually implement those things. For example, that knowledge graph I talked about. Ethical considerations are also there. Do no harm is first thing. We should not create issues for approval and approved indications actually. For example, in COVID in Poland, somebody tried amantadine because of its antiviral property, which was its actual original indication. Then it got repurposed as Parkinson medicine. But it was so popular and it was so much used in Parkinsonism that nobody was using it for viral uses. Now in COVID, a physician tried it, had some success. Everybody was in panic mode and purchasing amantadine. So much so that there was a shortage for its use in Parkinson's disease. And then the health authorities had to issue some regulatories and notice that it should be used for primary indication only, not for COVID-19. Similarly, repurposed antibiotics do run risk of antibiotic resistance. How to handle that? Then the other aspects like, are we overshooting things? Are we promising too much? What is the actual evidence base? This is an example of those repurposing related antibiotic resistance where levofloxacin and certain other medicines were tried for different indication, but it affected the primary indication by creating the resistance. So in short, this was just a bird's eye view of an effective strategy to find new indications for a drug as well as new treatment for existing diseases, especially when the treatment options are limited, like in cases of orphan diseases. It often saves time and resources. It does have its own limitation, but knowing about this repurposing thing and their different indication can help us manage patients more effectively and rationally. Thank you.
Thank you, Nachiket, for a very simple and a lucid presentation of a very difficult topic. And I think you took us through the semantics, the way it can be used, what are the challenges, how things are changing. And responding to that, we already have a few questions. Ashwin is asking, is it repurposed drug or multi-purpose drugs? Repurpose means that the first identification becomes the label one and the other condition becomes repurposed. Seems like yet to be discovered uses. Repurposing may lead to perception of the less important drugs, although its effect may be better. Because we yet say the primary is the one which is the, the one that it was originally being used for.
Yes, so actually that is very valid point. And when we talk of primary indication, secondary, it is by and large chronological. It's not that one indication carries more weight than other, but for one indication there was FDA approval. That molecule is already being used for that purpose. Let's say clinically we started using clomipramine and found that delayed ejaculation is its side effect. Then it got, in a way, off-label use or repurposed as treatment for premature ejaculation. So as far as term off-label is considered, it means that FDA approval is still not there for that indication. So most of our drugs are actually multi-purpose and we can get them approved for different indications, maybe for same dose or different doses. And that's why I would think that, especially in terms of psychotropics, I would actually like to see them get their due. They are doing more than one thing rather than just managing serotonin, dopamine, this, that. So at least if we can look at them as something in our arsenal that can help in multiple conditions, most probably majority of the non-communicable diseases, then we might probably come out of that mindset of psychotropics being non-essential.
But Nachikeet, just to counter that, is that then is it important to have that FDA approval? While we may think of many other reasons, and as Ashwin has said it, we may have a hypothetical effect. Is that enough to justify use as a significance, though it has not been experimentally proved? So can we just say repurposed, multi-purpose drug without the research backing? Is it possible?
No, ma'am. No, ma'am. Actually, repurposing does involve research. It just primarily cuts down the safety part before it enters in human trials.
The
Because
cost
it's
and length of
marketed, yeah, development length reduces, but it has to go through the proper research for this newer indication also. And getting FDA approved will carry some weight, more than one weight. Although FDA has jurisdiction in US only, but we do follow FDA approval, we do follow DSM.
No, or even if we take a DCGI approval,
Yes,
whatever
ma'am.
it is, eventually
For
we.
our part, DGCI.
So Ritvik is asking, what is the legal standpoint for repurposed drug? If we're using any repurposed drugs, can it be a legal liability, especially if it is not yet got a DCGI approval for that repurpose or reformulation or whatever that we are trying? So are we out on the limb when we do something like that?
We are as much out on limb as any other off-label use. If there is a regulatory body approval, let's say DCGI approval is there for endoxifen. Legal standpoint is very clear, it is approved molecule for mania in India. Other than that, there are molecules time tested, in existence for decades, yet have not got approval because nobody applied. So that part is, we are from legal standpoint in off-label use area.
That is where maybe IPS guidelines can help us. Coming back to this, Amrit is saying there's good data compilation and lucid presentation. He would love to hear about a few interesting cases seen and managed by you using drugs as a repurposed drug or reformulated or whatever. And if anybody else also would like to share after Nachiket about how they in their personal practice have used drugs differently and found use in them. Nachiket, would you like to share some case examples?
I would give just broad idea rather than individual cases. I'm living in a tier 2 city of roughly 3 to 4 lakh population, not more than that. But because we are a satellite city to a metro, we have onco services and other things. And there I started looking in these things, and I have actually applied these principles clinically. The clonidine case I was talking about was 45-year-old female with severe anxiety, not responding to benzodiazepines. And she responded to clonidine. It does have valid ground in hormonal area. Endocrinologists use clonidine for vasomotor and other menopausal symptoms. So if I could manage her those symptoms, anxiety symptom and pressure, all with clonidine, it would be ideal. One molecule fitting properly to this patient. Only thing is, she did not have that much of a hypertension. That's why physician was concerned. Similarly, if somebody has hyperarousal and related things, I have told physicians that if it is permissible from your side, let me choose either prazosin or clonidine. That can help with nightmares also, and it will help in your hypertension management also. Similarly, I have used olanzapine for onco patients who are on chemotherapy. Just 2 days back, I saw an onco case who had a history of CA breast in 2005. It was operated. Then there was hysterectomy. Now there is lymphoma, and she is on ARCHOP regimen. Vin Christine and I forgot the names. Now that lady is 75-year-old. She is presenting with some dementia-like symptoms. Now I am thinking whether this is related to primary condition, whether this is related to medicine, and if I can choose a molecule, what kind of molecule should I choose? This is still under process. I have not yet reviewed literature, so I don't have answer as of now. But I can say this is the process I follow.
But to a large extent, it is also falling back on your understanding of what could be the probable, hypothetical, or maybe expected mechanisms or circuits that could be involved, and therefore making an attempt to repurpose and use that. And I can see that Ritvik has his hand up. Ritvik, is it a question, or would you like to share a case?
Just to share, ma'am, actually the one of the point that Nachiketa presented was using metazapine or TCA for IBS. So this is something I've had a lot of uh, success with, and a couple of patients which I recently saw. Now in psychiatry, we tend to get a lot of graveyard diagnosis where everyone else has said, okay, this is not something in our field, it is most likely a psychological thing. And when they come to us, we tend to see that. So, with like recently, I had like couple of patients of cyclical vomiting, and they responded really well to metazapine. So, the point was not that we are giving metazapine only for like say depression or something else, but it was excellent for cases of cyclical vomiting is what I saw.
Thank you.
Similarly for migraine also.
Go ahead,
If I,
Ritvik. Thanks,
yeah,
Ritvik, for sharing. If you had something
Yeah,
to say.
so metazapine is good agent for migraine also. It has evidence base. Somebody wanting to gain weight and want to deal migraine and anxiety, kill three birds in one stone, metazapine.
yeah. So I
Maharaj,
can,
you are
if
saying
I
also.
if I can add a couple of points here. First, I would like to start with what Ritvik had just mentioned, that what is the legal standpoint of repurposed drugs. So my line of thinking is that if a drug is available in the market, approved by whichever authority, whichever country we are in, uh, it is up to the clinician to decide how to use the molecule. It may be for the indication for which it is approved, and by off-label, it would mean indications for which it is not yet approved, but can be used safely because the safety has been established. Now, when I am using a molecule, I mean, in fact, if I can think aloud, uh, all the molecules that we use in psychiatry, all of them, each and every one of them, we use off-label more than just approved. So we are using most molecules, all molecules off-label. Because if you even look at the chart of SSRIs, there is one SSRI approved only for panic disorders, one SSRI approved only for OCD. So does that mean that we are not going to use that for depression as well? So my point is this, that if we are using a molecule for an indication that is different, what kind of evidence is needed? Do we want an RCT, or do we have enough number of case series? Because on the hierarchy of evidences, even though case series or anecdotal reports are not, kind of up to that grade 1 level, still it is evidence. So legally, if I am using a molecule, because one, it is not harming a patient. So it stands by that first rule of primum non nocere. And secondly, if we have some case reports, I think that should be more than enough evidence for use in a particular patient, whether it is off-label. I think that that should stand, because it is, after all, the clinician is going to decide what is going to be the right approach. Secondly, whenever there are RCTs done, they are usually single RCTs for any disorder. And the patients who come to us are not those patients who have been selected for that particular RCT. Because in an RCT, the intake criteria are pretty rigid. Whereas in the clinics, everybody comes with a combination of problems, a combination of comorbidities, whether it is psychiatric, whether it is physical. So that so from day one, it's going to be a combination of molecules which are going to be given to a patient, and it's not going to be one molecule. So it's best we know how to combine molecules. Another thing that I wanted to point out is, with regard to what Dr. Ashwin Mohan has mentioned, that if that is his first question that Dr. Hinel took up, is it repurposed drugs or multi-purpose drugs? And I think if we consider what is happening with semaglutide today, GLP-1 agonist. Now, what Novartis is doing, or rather has done and is in the process of doing, is that it came out as an approved drug for T2 diabetes, T2DM, diabetes mellitus. It doesn't reduce blood sugar, but it reduces appetite, by which things get more streamlined. Appetite is reduced, insulin resistance is less, glucose tolerance is better, weight loss is there. People are using it more now for weight loss. They have studies on that. So Novartis has got studies for management of T2DM. It has got studies now for managing weight. It has got studies which is where the intake population is a non-Caucasian patient, so Asian individuals. So what I think they're doing is they're taking care of repurposing right from day one. So the drug is actually multi-purpose and not anything else. Smaller studies in the pipeline for semaglutide are for cognition improvement, depression, and some amount of impulse control. So I think this is the approach which the company is taken. It has kind of covered everything. And, repurposing semaglutide apart from all these things, it's going to be a difficult task. So probably they are on the right track. Once they have a molecule, they are doing study after study to figure out how it can be used. And we know that it is probably the most successful medication in history as of now, because it is targeting very, very core kind of illnesses or non-communicable diseases. So that was my take on, this a couple of questions that were put up. Nachiketa, another one for you. What is the repurposing of cannabidiol apart from what we are told? What are your thoughts on that?
So first thing is whether cannabidiol had already existing any indication or not. As far as I understand, its use in epilepsy is probably his first indication in our modern medicine. Before that, it has been used in experimental procedures or maybe as we see in substance use disorders. So there is that. But assuming that its primary use as anti-epileptic is already established or came first even by the margin of few months, and then we started using it in pain and inflammatory conditions, then until it gets approval for that indication, we are calling it off-label use. However, exact timeline, I don't have clear idea about whether it was actually intentionally repurposed or like sir said, it had some similar mindset like semaglutide, where company was already targeting different areas.
Ritvik is asking, if we do find a drug which is good for repurposed indication, how do we go about getting it approved? Does it fall on us or the pharma companies? I think, Ritvik, there is not possible for an individual to do this. It is a mechanism of how we get these drugs done. You can bring it to the notice of the pharma companies and get them involved and get them to do the research and, get it done. And I don't think it is possible for a single person to do that. While we were talking of semaglutide, we also know the semaglutide has been also been thinking about using it to reduce alcohol consumption in individuals with obesity. So that's another indication that is coming up. So sometimes you wonder, is it just the our understanding of diseases that's improving, or is it serendipity that realizes and repurposes drugs, and then eventually that repurpose becomes the main purpose? So semaglutide is going all over the place, as Malay has said. So we have to wait and watch how it goes.
Okay. Uh,
May I speak something, Dr. Bodhani here?
yes,
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 sir.
sir.
please.
As far as legal aspect is concerned, I think we are good that we are in India, where nothing happens about legality is concerned. We are free to use anything, anywhere, for anything. So I remember very well that during my PG days, we were using chlorpromazine 10 milligram as a beautiful anxiolytic drug when many times we didn't like benzodiazepines. Diazepam was, of course, available, but because of very sedative effect, we used chlorpromazine only 10 milligram, not only for anxiety and good sleep, but for psychosomatic disorders. Same was for trifluperazine. So these are the drugs, antipsychotic drugs we used to give very frequently, almost 10 to 15 cases per day in OPDs of maybe say 100. So these drugs were freely used by physicians, by psychiatrists, by everyone, without any fear, without any fear of say legal things. So we were not worried about. We were interested in patients' benefits, and they were getting benefited. So we used them. So when I remember using when clonazepam came, I used as an anti-panic, and many people were saying why you are using anti-epileptic drug for. It was marketed for anti-epileptic drug, and I used to give a lot of Inderal, propranolol for migraine in 40 for 50 years back, and everybody was talking about it's not why use in normotensive people. But I knew the effect and I knew the result, and they were very happy. So repurposing, multi-purpose is in our hands. We should think of the use and proper use and ethical use. So nothing legality comes in the picture. This is my person. Thank you.
We let know Bhaskar that he was missed. I can see a comment that he should be here because he's caused a whole generation of people to repurpose use of drugs. Ritik, is that a fresh hand that you have up there?
Yes, ma'am. Just to add to Dr. Amrit's point, I think, we need to understand our drugs in all other systems as well, because diffusion works that way, and any drug that we're giving is going to go to each and every part of the body, not just the brain. So I think we need to really understand what our drugs are doing to the other parts of the body, not just the brain as well.
True, and we should have newer and newer research in that direction that helps us to understand it better. And many more discussions on life CME besides bashing of psychologists. Any more questions that are there for Nachiket or Malai? I
I
like
think
the way Dr. Amrit has said that we should not worry about legal. I'm a little more skeptical about not being worried about legal, of course, with a good intention, but things are tightening up over here also. So we just have to be clear in our indication and have documented all of that, maybe consulted somebody and then gone ahead. All yours, Malay.
yeah. So what this kind of a topic brings to us, the food for thought is that whether we are psychiatrists or whether we are other physicians, uh, we are still understanding the basic pathophysiology of illnesses. So in any branch of medicine, um, we are not completely there. We have a better understanding of certain processes in certain specialties, and when it comes to psychiatric illnesses, we get stumped. But the point is this: the shift of understanding and research when it comes to chronic non-communicable diseases like psychiatry and cardiovascular disease or neurological disease, degenerative problems, um, autoimmune disorders, and things like that, is that there are certain core uh, systems, physiological systems. By that, I don't mean organ systems. These are systemic processes. Means these are, let's say, if we take the case of inflammation, Inflammation is a full body process, physiological as well as pathological. When we look at oxidative stress, it is a full body process. Now, when we have this kind of basic processes in play, if a basic physiological process gets affected or goes haywire because of whatever, because of a faulty design, which is genetic or epigenetic, or something ticks it off badly, let's say a viral infection. When we have this kind of a core process, the organ system, which is most sensitive to disruption of this system, gets affected and will have symptoms of that system. What is now being understood is that psychiatric disorders or psychiatric illnesses that we diagnose and we treat may not have their origins only in brain function. There are certain features, there are certain physiological systems which are not working okay, and brain, being a very sensitive organ to change, gets affected the most. Means this basic pathophysiological process is going to affect each and every system of the body: cardiovascular, muscular, renal, everything. But brain, being most sensitive, will produce the maximum number of systems, and this symptoms we kind of combine in certain permutations and combination and we say it's a psychiatric illness. That's why we are kind of drawing a blank when it comes to, we know so much about neurobiology, so much about neuroscience, but what is exactly happening, where it starts, how it goes, and why there is a great amount of overlap, genetic overlap or an epigenetic overlap among psychiatric illnesses, that is something that we have not been able to answer very satisfactorily. So once we understand these basic processes and we understand the effect of the pharmacological agents that we have at our disposal, then things become very clear. That when you, let's say something like minocycline, an antibiotic, yes, it does have an effect on certain kind of bacteria. But what effect does it have on the inflammatory status in an individual at that time? And if that inflammatory process that is going on gets satisfactorily managed, then some studies have shown that in certain patients of schizophrenia, chronic schizophrenia or resistant schizophrenia or negative, there is certain effect. But if you look at it in large numbers, that is not the case. So again, there are certain variations. So this kind of topics is not only about how we are going to use medications that we have at our disposal in various conditions, or other medication, in the sense medications from other specialties, how we can apply to our group of disorders that we deal with day in and day out. But it should prompt us to think differently as to what is causing the symptoms. We have got very, very, very superficial understanding of what symptoms are. We have names for that, but what is just under it, even, I would say we have not even really scratched the surface that much. So this kind of topics are, kind of clinically important, because we have to treat patients, but also at a basic level, what can be going wrong by which a certain molecule that we have not dreamt of being used in psychiatry becomes important, and how we can, systematically use it better. So, Dr. Hinal Shah, for your last few comments.
Like you said, Malay, it really is for us to look at not only the tree but the forest, because our understanding of psychiatry, and especially with this whole new wave of looking at personalized psychiatry and thinking that we really need to understand mechanisms, including genetics, besides all the mechanisms of how the body and the brain works, understanding all this together to hopefully do better for our patients should be our aim. And Nachiket has very lucidly, kind of summarized what are the terminologies, how it can be used, given some examples, challenges, talked about legality, and Malay has left us with a lot of food for thought. And I think with this, I thank again Nachiket, Malay, Bhaskar, Rukshida, and Dr. Rajkumar for this wonderful session, and hand it over for the final byes to Malay.
So we conclude yet another interesting session on the Brain on Wednesdays. I thank you all for spending your Wednesday evening with us and participating in the discussion. I hope with topics like this, all of us get to know something more, get to understand things better, and kind of take up the uh, the biology as one of the common denominators for whatever is going wrong with our patients. I thank Dr. Rajkumar. I mean, he couldn't make it today. I thank Dr. Hinal Shah for chairing this session today. I thank Nachiketa for a wonderful presentation. And lastly, I thank Alchem for their generous sponsorship for the program. Thank you, everyone, and good night. We hope to see you on the second Wednesday of August now. Thank you so much. Good night.
Good night.